Thanks. Take it away. Okay, thank you all for coming. Thank you, Sarah, for coming in person. Honestly, I didn't expect to see you. I thought you'd join by Zoom. Okay, thank you all. Thank you also for those who joined via Zoom. Today I'm going to present on extended outcome investigations with a specific focus on missing viral loads and measurements among adults living with HIV in Kenya. The HIV response has greatly reduced mortality globally and in sub-Saharan Africa, including Kenya. More than 1.5 million deaths have been averted by the introduction of ART. An effective viral load monitoring system is critical to early intervention and prevention of poor health outcomes among people living with HIV. Gaps in HIV RNA monitoring impede the ability to determine and shape clinical progress and outcomes, but they remain common in practice. These gaps are due to complex and multi-level health system barriers impeding progress toward the epidemic control. Incomplete viral load monitoring raises the risk of missing broader trends within the population. Without a comprehensive viral load monitoring system, it becomes difficult to accurately assess effectiveness of treatment programs at the population level, implement targeted intervention, and allocate resources where they are most needed to control the spread of HIV and improve treatment outcomes. To better understand issues leading to these gaps, we developed an algorithm for assessing root causes of missing HIV RNA. We refer to this as an extended outcome investigation approach. This systematic method assesses if viral load is truly missing and determines the contribution of provider system and patient-based reasons for missing viral loads among a cohort of adults living with HIV in Kenya. The aims of this study were: 1, to determine the prevalence of missing viral loads among adults on ART enrolled in the study; 2, establish reasons for missing viral load measurements; and 3, examine patient characteristics associated with missing viral loads. This is a cohort study that was designed in a larger sequential multiple assignment randomized trial SMART, the ADAPTER study. So ADAPTER stands for Adaptive Strategy for Preventing and Treating Lapses of Retention in Adult HIV Care, ADAPT-R. Just a brief of this ADAPT-R study. So the study ended about 2 years ago. So the study evaluated strategies for optimizing retention in HIV seropositive individuals in care in Western Kenya. So participants were recruited and enrolled from patient support centers, commonly known as the CCCs, in Kisumu and Migori counties. Participants were randomized to either 3 of stage 1 intervention. So we had an SMS arm, the short messages arm. We had a CCT. CCT stands for conditional cash transfer or voucher. And we also had the standard of care. So at stage 1, at study enrollment, participants were randomized to either of these 3 stage 1 arms. Then upon failure, and failure here is defined by missing your appointments by 14 days, they were randomized to a higher intensity arm, stage 2. So this higher intensity arm was a combination of either SMS and voucher or a peer navigation arm or standard of care, but with intensified counseling. So that was for the main study. And the population in the main study were adults living with HIV and AIDS who are above 18 years of age. Those who had initiated ART within 90 days and had access to funds and were willing to be contacted by the clinic. Back to this sub-study, we included all ADAPT-R participants who had a missing viral load measurement. And we measured viral load at 2 time points: 1 year post-enrollment into the study, which was coinciding with 1 year post-ART initiation, and then at the end of 2 years. So we included these participants who had a missing viral load measurement, and And also they had the extended outcome form filed for them. The guidelines, the study and the participating health facilities followed the ART guidelines for viral load monitoring, which recommended that viral load testing was to be conducted 6 months and 12 months post-ART initiation, and annually thereafter for adults with viral suppression. At that time, before the viral load guideline change, suppression was defined as less than 1,000 copies per mil. To data collection, the socio-demographic and clinical characteristics of participants were captured at study enrollment, and this was between March 2015 and October 2018. We obtained these characteristics from our database. Some of the variables we included were age, gender, and some clinical characteristics such as the WHO staging, study site, and the viral load history. To the extended outcome investigation, to examine viral load missingness and the reasons for the missingness, we employed a two-step process. Step one was outcome ascertainment. During step one, a monthly generation of reports listing participants with missing viral loads during the established windows was generated. And our windows here were 9 to 15 months in the first year and 21 to 27 months in the second year. And all this was post-ART initiation. So we compared this list with the clinic records. And if the viral loads that we were finding, these results were documented, and then we omitted or removed participants from this list. The remaining lists now they moved to step two. And in step two is where we had the ascertainment of reason for missing this viral load. So in step two, we did an in-depth review of the patient's file, the entire file, repeated the review with the electronic medical records, the laboratory records, and also the NASCOP EID website where the viral load results used to be. We then consulted the research assistants for participants in their caseload. So our research assistants had participants who were in their caseloads, and they used to follow up with those participants had viral loads that had been done. And if at all viral loads had not been done, the reasons why these viral loads were not done. Then we classified reasons for missing these viral loads based on the review of these patient records and consultations with both the clinicians and the research assistants. Our outcomes focused on patient status at the window period of interest, and this included death, official or self-transfer to another facility, and non-transfer. So for those who transferred to other facilities, we had information about the transfer, so we could call to obtain this information. For self-transfers, we could also call the participants, and a good number would inform us that I transferred to this facility, and we were able to collect the outcome we wanted. So for participants who had not transferred, they were still within these ADAPT clinics. We had to go back and review their files and check if this patient had a clinic visit during that window period, because we've already classified them as patients who missed viral load. So we had to go back and confirm, did this patient attend the clinic during the window period? And if they did, clinic factors were examined to determine if it was a clinician decision not to order viral load, or viral load was ordered, but it was either not collected because the patient didn't show up at the lab, or the patient went to the lab, the viral load was collected, but the sample was lost. Documentation was then done in our extended outcome investigation form and entered in ODK. For our aim one, the analysis, so missed viral load was defined as no viral load results within the window periods, that is 9 to 15 months in the first year and between 21 to 27 months post-ART initiation in the second year. So for aim one, we used descriptive statistics to determine the prevalence of missed viral load and reasons for missing viral load measurements. We conducted a complete case analysis by excluding missing values. And then for aim two, a generalized linear model using a Poisson distribution with log-link function was used to estimate the adjusted risk ratios to determine patient-level characteristics that are associated with missed viral loads. And then under the socio-economic status, because that was one of the variables that were obtaining from a sociodemographic form. We generated the indices using a multiple correspondence analysis with variables that were in a socioeconomic form. These variables included household head, primary source of water, type of cooking oil, ownership of household, and we then categorized them into 5 quartiles: poorest, poorer, middle, richer, and richest. The table just shows some background characteristics of participants in the first and the second year. So overall, among the 1,754 participants whom we investigated, 66% were females, and 46% were aged between 24 to 34 years. And again, about 54% received care in urban clinics. Going to the frequency of monitoring viral load, the frequency of monitoring viral load was at about 72.3% in year 1 and 68.9% in year 2. However, we had some delays whereby about 15.6% had a delay in year 1 and about 7.1% had a delay in year 2. And delay here were participants who missed viral load during the window period, but later they received their viral load tests. The prevalence of missing viral load in year 1 was about 27.6%, whereas in year 2, it was at 30.4%. When you go to the reasons for missing viral load in year 1, about 51.1% were lost to follow-up. That's why they didn't have their viral load measurements. And then we had misinterpretation of viral load guidelines on monitoring timing among clinicians. This led to about 36.7% of participants missing on their viral load measurements at that time. We were not able to establish reasons why about 10.3% of some of these patients missed their viral load. However, we have some patients who were sent to the lab, but samples were either not collected or sample was collected but was lost, and this was about 1.5%. Similarly, in year 2, 57.8% missed their viral load because they were lost to follow-up. Again, we had about 32.2% whom the clinicians did order because of the misinterpretation of the guideline and the monitoring timing. We could not account for about 8.6% because the files really didn't give us information on why they didn't order the viral loads. And about 1.3%, there was no evidence of sample collection. And among those whose samples were collected, they were either lost, so we didn't have those results. We also had cases of presumed non-adherence among clinicians, hence they were not ordering these viral loads. And it's something that they were not documented, so it was really hard to account for it. Going to associations, which was our aim 3, looking at patient characteristics that were associated with missing viral loads. Slide is busy, but I'll just highlight the key things. So patient characteristics associated with missed viral load in the first year were younger ages, less than 24 years, compared to those who were above 44 years of age. And then higher socioeconomic status was also associated with missing viral loads in year 1 compared to those who were in the poorest category. And again, receiving treatment at a rural clinic was also associated with missing viral loads during the first year. Similarly, in the second year, same age category, below 24 years of age, the younger population had a higher risk of missing viral load compared to those whose age group was above 44. Participants whose socioeconomic status were richer also had a higher risk of missed viral load compared to those with the poorest socioeconomic status. And participants who were categorized as WHO stage 4 also had a higher risk of missing viral loads compared to those stage 1. When we did a stratified analysis, just comparing rural versus urban facilities. There was no change in association with missed viral load in year 1 and year 2. So before I conclude, I would just like to say that we were not able to establish other factors that could have led to missed viral load, like machine breakdown, reagent stockouts, or even the impact of healthcare worker strike on HIV care and treatment. Also, during the investigation process, we were obtaining viral loads, but at the end of the process, we were not able to account for how many viral loads were we able to identify during this process. And finally, we had information on participants who had transferred to other health facilities. We tried as much as we could to get their data, but we had limited outcome data. Just to conclude, missed viral load monitoring remains high, and still losses to follow-up is a major source of missing information. And this could alter overall suppression calculations substantially, in addition to providers actively not monitoring patients, especially those at risk of viremia. It is important for us to know the prevalence of missing viral load values at specified time intervals after treatment initiation, because this provides a structured approach to assess response to ART among patients, and it is also essential for optimizing monitoring efforts, improving patient outcomes, and also ensuring efficient allocation of resources in HIV care settings. Therefore, sustainable approaches to keeping people living with HIV engaged and strengthening providers' alignment with national guidelines and how public health systems make most of viral load monitoring technology among patients living with HIV. I would like to acknowledge the Women at HIV grant, the Sarah Maicha, who is here, and the WashU mentors, the Ministry of Health in Kenya, the Kenya Medical Research Institute, and the study participants. Thank you.